Welcome to This Explainer. Today, we are diving deep into the highly specialized and honestly sometimes complex ecosystem of modern critical care. If you've ever felt completely overwhelmed by the sheer scale of a hospital or that alphabet soup of medical jargon, well, you're in exactly the right place. We're going to break down how hospitals organize their most intensive care units to save lives, and more importantly, how understanding this whole shebang can actually empower you to advocate for yourself or a loved one when it really matters most. Let's get into it.
Now, we've all heard the phrase, right? They were sent to the ICU, usually on some dramatic TV show or the evening news. But thinking of critical care as this one single uniform place is actually a massive misconception. In modern medicine, there is simply no such thing as just the ICU. It's not just one big room with a bunch of beds and monitors. And unpacking why that is, well, it's going to completely change how you look at hospital care.
So here's our roadmap for today's explainer. 1. The critical care landscape. 2. Decoding levels of care. 3. Open versus closed units. And finally, number 4, what happens beyond the ICU walls.
All right, kicking things off with Section 1, the critical care landscape, or as I like to call it, the alphabet soup of specialized care.
Walking into modern critical care can feel literally like drowning in an alphabet soup of acronyms, right? You've got the CCU, CVICU, SICU, PICU, and so many more. But believe it or not, there's a brilliant logic to all this chaos. Care is completely tailored to individual organs, distinct age groups, or very specific traumas. Think about it for a second. You definitely wouldn't want a heart specialist managing a severe burn or a pediatric nurse trying to calculate medication doses for an 80-year-old trauma patient. This hyper-categorized environment guarantees that a patient's unique, specialized needs are met by highly specialized experts right from the moment they roll through the doors. Once we actually categorize all this chaos, it starts making perfect sense. Just picture a patient recovering from open-heart surgery. They absolutely need the intensely monitored, highly specialized environment of a CVICU. That is an entirely different universe compared to the NICU, which is precisely calibrated for tiny, premature newborns, or the burn ICU, handling complex skin grafts and severe infections. By dividing things up into cardiac, trauma, neurological, and pediatric centers, along with those transitional spaces like the PACU, the post-anesthesia care unit for right after surgery, hospitals make sure every single patient gets exactly the right kind of attention they need.
Moving right along to Section 2, decoding levels of care. Because as it turns out, not all hospitals are equipped equally.
So stepping back from those individual rooms on a floor, we really have to look at the hospitals themselves as a whole. Basically, there are 3 distinct levels of care out there in the critical care environment. And why is that? Well, quite simply, not every single hospital has the massive infrastructure, the insanely expensive equipment, or the specialized teams on standby to manage the absolute most severe illnesses. Grasping this hierarchy is just absolutely vital, especially for medical staff. They need to anticipate exactly what resources they have in their back pocket for their specific patients at any given moment.
The real-world difference between a Level I and a Level 3 facility? It's massive. A Level 1 facility is your heavy hitter. It provides comprehensive care for a huge variety of incredibly complex disorders, boasting continuously available, highly specialized staff and top-of-the-line technology. A Level 3 facility, on the other hand, acts more like a crucial, immediate safety net. Its main focus is just the initial stabilization of critically ill patients, meaning they have a much more limited capacity to provide that comprehensive, long-term critical care.
Let's zoom in on those Level I units for a second. You usually find these in large teaching or academic hospitals, and they offer so much more than just fancy, sophisticated machinery. They feature this massive, non-stop web of continuous support services. We're talking around-the-clock access to an in-house pharmacy, specialized nutrition, respiratory therapy, and even things like pastoral care and social work. It's essentially this all-encompassing, holistic environment custom-built to handle the absolute sickest patients in an entire region without ever skipping a single beat.
Now, swinging to the other end of the spectrum, Level 3 units are absolutely essential. They act as the very first line of defense for communities that just don't have immediate access to higher-level services. So if someone suffers a major medical event out in a rural area, this facility is going to save their life by stabilizing them. But here's the catch. Because those comprehensive specialty resources aren't physically in the building for the long haul, having strict, written transfer policies literally becomes a matter of life and death. These protocols spell out exactly who needs to be moved to a Level 1 or 2 facility for definitive care and exactly how fast that transfer has to happen.
All right, on to Section 3, open versus closed units. Or, to put it another way, who is actually managing the patient's care?
So, Once a patient is stabilized and tucked into a bed, this huge operational question pops up. Behind the scenes, who is actually calling the shots? Well, it all comes down to whether a critical care unit is considered open or closed. And let me tell you, this concept drastically alters how a hospital runs day to day. It completely dictates the chain of command for a critically ill patient.
Here's how it breaks down. In an open ICU, the patient's primary admitting doctor, say the surgeon who just operated on them or their general hospitalist, they stay in charge of the overarching care. They are steering the ship, and they only call in critical care consultants when they feel it's really necessary. But in a closed ICU, it's a totally different ballgame. An intensivist-led critical care team assumes primary responsibility the second that patient rolls through the doors. That specialized team takes over completely. Now sure, some hospitals use a bit of a hybrid approach depending on their staffing, but generally speaking, these two management styles are just entirely different worlds.
So why does this closed model matter so much in modern medicine? Well, it's because these providers specialize exclusively in critical illness. When patient care is directed entirely by dedicated intensivists, it almost always leads directly to more standardized protocols, vastly better communication across different medical disciplines, and, most importantly, improved patient outcomes. It just makes sense, right? The specialists who know the absolute most about critical care are the ones making those life-or-death, minute-to-minute decisions. Which brings us to our final section. Section 4, Beyond the ICU Walls. Let's talk about the rapid response team.
You see, modern critical care isn't just locked away on a specific floor behind some sliding glass doors. It is a highly dynamic, mobile, hospital-wide ecosystem. Enter the Rapid Response Team, or RRT. They're designed for one incredibly high-stakes workflow. First up, early identification of a patient who might be deteriorating in just a standard, non-critical hospital room. Second, rapid active management by a multidisciplinary team that literally rushes straight to that bedside. The ultimate goal here? To completely head off a catastrophic cardiopulmonary arrest or an unexpected transfer to the ICU. Basically, the rapid response team brings the intensive care unit directly to the patient, stopping danger in its tracks before it ever escalates.
But hey, no system is totally flawless, right? There are actually some surprisingly human barriers to activating this amazing life-saving team. Even when an RRT is fully staffed and ready to go, things like simple interpersonal friction between a responding nurse and the nurse trying to call them can cause critical, dangerous delays. Sometimes there's even pushback or undue influence from the patient's primary physician. Or, honestly, it can just come down to the confidence, experience, and education level of the nurse activator, whether they actually feel empowered to sound the alarm. It's a pretty fascinating reminder that medicine relies just as heavily on human psychology and communication as it does on all that hard science and technology.
So we've seen just how specialized, intricately structured, and mobile this entire critical care ecosystem truly is. It takes a massively coordinated web of professionals and resources to save lives every single day. Which leaves us with a really vital question to ponder. Does your local hospital actually have the right level of care for every single emergency? Understanding the specific capabilities in your own community really empowers you to navigate those critical moments and to ask the right questions if you ever find yourself needing to advocate for yourself or a loved one. Thanks so much for joining me for this explainer. Keep learning, stay curious, and always keep asking those great questions.